Assessing the cognitive trajectory of an infant requires measuring milestones that are incredibly subtle. Before a child can speak or walk, practitioners are looking for the precise timing of a grip, a gaze, or a reflex to map the development of their central nervous system. When those developmental milestones are severely delayed or missed entirely, the clinical classification is intellectual disability, historically referred to in medical literature as mental retardation. By definition, this is strictly a congenital or early developmental condition. It occurs before the brain has fully matured. If a patient experiences a loss of cognitive function late in childhood or during adulthood due to physical trauma or disease, that is classified as an acquired cognitive decline, not an intellectual disability. To confirm a diagnosis, the clinical standard requires two specific metrics. First, as this chart illustrates, the patient's intellectual functioning, or IQ score, must test strictly below 70. Second, there must be a documented deficit in daily adaptive functioning. The patient must show a measurable inability to learn basic life skills, adapt to new situations, or perform daily routines independently. Looking at the global epidemiological data, this developmental block affects approximately 3% of the total worldwide population. In India, specific regional monitoring shows an incidence rate of roughly 5 in every 1,000 children. Across these populations, demographic tracking consistently shows a distinct vulnerability in males compared to females. Effective clinical management depends on moving past the IQ score to identify the exact biological moment development was compromised. The timeline of vulnerability begins at the exact moment of conception. Long before any physical fetal tissue begins to form, the biological blueprint is already being written. Endogenous genetic errors form the first tier of risk. If the chromosomal blueprints contain inherent structural flaws, the central nervous system will be physically unable to construct the necessary neural pathways later on. Down syndrome, or trisomy 21, is a direct result of a pathological addition. A third chromosome attaches to the 21st pair, altering the genetic code required for normal brain maturation. Anomalies also frequently target the sex chromosomes. Trisomy X occurs when an entire extra X chromosome is mistakenly duplicated during cell division. Conversely, Turner syndrome is defined by a critical absence. Also known as 45XO, it strips away the second sex chromosome entirely, leaving only a single X to dictate developmental coding. Beyond whole chromosome additions or deletions, cognitive limits can be set by the loss of microscopic chromosomal fragments. In Cre-Du-Chat syndrome, the upper structural segment, the P-arm, of the fifth chromosome is physically deleted. Prader-Willi syndrome presents a parallel mutation, occurring when the 15q chromosomal arm is severed and lost. These endogenous mutations dictate a fixed biological ceiling. They permanently hardwire cognitive limitations into the patient's cellular makeup before a single fetal brain cell has even begun to grow. Identifying a genetic mutation is straightforward, but understanding the actual mechanism of cognitive decline requires looking at how a microscopic anomaly disrupts physical brain chemistry. Fragile X syndrome provides the clearest pedagogical model for this process. Embedded directly on the X chromosome is a specific sequence known as the FMR1 gene. In a healthy sequence, the primary function of this gene is to manufacture Fragile X mental retardation protein, or FMRP. FMRP acts as specialized cellular scaffolding. It physically constructs the microscopic bridges between the dendrites of adjacent neurons. These connections are what allow electrical signals to travel. Building a dense, highly interconnected neural network is the physical requirement for high-level learning, adaptation, and memory formation. The Fragile X mutation completely disrupts this assembly line. The mutated gene shuts down the production of the FMRP protein entirely. Without FMRP, neurons cannot physically link together. The networks remain isolated, synaptic communication hits a dead end, and cognitive processing halts. Intellectual disability here is not an abstract concept. At the cellular level, it is a stark mechanical failure of synaptic bridging.
Moving forward from conception, the timeline enters the active gestational, or prenatal period, where physical brain tissue begins to form. Even with flawless genetics, the growing fetal brain is highly susceptible to severe metabolic and structural errors during this phase. In metabolic conditions like Wilson's disease, the body loses the ability to process elements safely. Toxic accumulations of copper build up and aggressively interfere with the developing brain and liver tissue. This medical illustration highlights how fluid dynamics pose a major structural risk. As shown on the left, hydrocephalus occurs when excess cerebrospinal fluid accumulates, dangerously enlarging the fetal skull and compressing delicate brain mass. Conversely, a condition known as microcephaly presents the exact opposite structural failure, an abnormally small cranial vault housing an underdeveloped, restricted brain mass. Beyond internal errors, the developing brain faces exogenous threats introduced entirely through the maternal system. Chronic maternal conditions, such as severe hypertension, diabetes mellitus, and systemic substance abuse, restrict necessary nutrients and introduce toxins that directly impair fetal neural architecture. There is also a highly specialized class of infectious threats, known by the clinical acronym TORCH: toxoplasmosis, other agents like syphilis, rubella, cytomegalovirus, and herpes. These pathogens actively bypass the placental barrier to infiltrate the fetal blood supply. The placenta is not an impenetrable shield. Because it is highly permeable to these specific pathogens and toxins, maternal physiological health is directly equivalent to fetal cognitive viability. The timeline reaches its most concentrated threshold of risk during the perinatal period, the mechanics of delivery itself. A difficult delivery places extreme mechanical stress on the infant. Prolonged labor or sudden fetal distress forces the central nervous system to endure a volatile physiological environment. If birth is premature, those risks compound exponentially. An underdeveloped central nervous system is abruptly forced to function independently, without the biological support of the mother. The ultimate danger during this transitional window is the loss of oxygen, known clinically as asphyxia or profound hypoxia. Neurons require continuous oxygen to survive. Depriving the developing brain of it at this exact moment causes rapid cell death, irreparably halting cellular maturation. Once delivery is complete, the vulnerability timeline shifts into its final phase, the postnatal pediatric period. Here, the threats are direct and environmental. Acute physical cranial trauma or severe central nervous system infections, like meningitis and encephalitis, can rapidly degrade a previously healthy brain. Furthermore, extreme socioeconomic factors, such as severe poverty, physical abuse, and chronic neglect, flood the infant system with neurodisruptive stress hormones, impeding cognitive growth. Even a perfectly gestated infant with flawless genetics remains highly vulnerable. Acute environmental traumas in these early stages can easily trigger permanent intellectual decline. Looking across the entire chronological matrix of intellectual vulnerability, a clear clinical picture emerges. Intellectual disability encompasses an incredibly broad range of distinct pathological origins. Psychiatry classifies it as a final common pathway, the shared endpoint of diverse neurodevelopmental disruptions. The causes are vastly different. An endogenous chromosomal deletion at conception requires a completely different mechanism of action than an exogenous TORCH infection during gestation or profound hypoxia at birth. Yet, regardless of the origin, the clinical result converges on the exact same endpoint: the failed maturation of the brain's cognitive and adaptive networks. For medical and nursing professionals, grasping this overarching pathophysiology is the foundation of patient care. Precisely identifying where on this timeline the developmental block occurred is the only way a practitioner can move beyond a basic diagnosis. It provides the exact biological context needed to design and deliver highly tailored, effective psychiatric interventions.